Coming to Renovate trial, high flow versus NIV. So whenever we come across a trial, first thing is a clinical question. We should be confident and we should get satisfied with this particular clinical question, whether it's relevant to our current clinical practice or not, right? So the particular question in this particular trial is that in adult patients with acute respiratory failure, does the use of high flow nasal oxygen compared to non-invasive ventilation reduces the rate of endotracheal intubation or death at 7 days. Okay, will HFNC compared to NIV decreases intubation or death? Or death, it's not and death, it's or death at 7 days, right? So the moment you see this question, the next thought process is, why are they repeating the same trial, right? This is what the Florali trial also tells us, right? So when you have Florali trial in hand, then why should you need another trial? Okay, so maybe when there is already a predetermined trial, if there are enough exclusion criteria in that particular previous trial, you can include them and conduct a new trial, right? Or if you find any flaws in the previous trial, you can conduct a new trial. Or if you want to ascertain whether that particular effect is there in your population, under your genetical conditions, under your environmental condition, under your treatment protocols, then you can repeat the trial, right? So when I have a previous trial like Florali, then why should I bother about this Renovate trial? So this particular trial should answer all these questions, right? So the clinical question here is, will HFNC improvise intubation rates and mortality rates? The background is both HFNC and non-invasive ventilation have been used to treat acute respiratory failures due to various causes. See, this terminology, various causes, is not so good terminology, right? Various causes meaning it could be used for any type of respiratory failure. It could be used for COPD, it could be used for a pneumonia, it could be used for a ARDS, a pulmonary edema, it could be various reasons, right? But when you walk in your emergency department or when you walk in your ICU, the patients who are sitting in that bed 1, bed 2 and bed 3, they are not going to be like various causes patients. Bed number 1 is acute pulmonary edema. Bed number 2 is ARDS. Bed number 3 is viral pneumonia. They are going to be very specific, right? So any trial which is being conducted with a mix of population, if it comes out with the outcome, then it's going to be less likely for me to apply on a particular patient. For example, there's one trial, okay, trial 1. This has taken generalizedly that any patient with acute respiratory failure, any patient with acute respiratory failure, it includes COPD, it includes viral pneumonia, it includes ARDS, it includes pulmonary edema, whatsoever. It includes every type of patient, but no subclassification has been done. Okay, so subgroup analysis is never done. It's just taken a mix of all the patients. Okay, and it has come to a conclusion: HFNC is working better. HFNC is better. If such a conclusion has come, then if I walk into my emergency department with a patient who is having acute pulmonary edema, then it will be difficult for me to apply this outcome into my patient, because I really don't know what is the subset among this is acute pulmonary edema, what subset among this is ARDS, what subset among this is viral pneumonia. I really don't know, right? So a study which tells about various causes, you need to go look into the subset of this. Okay, did it really perform well in your type of patients? I need to apply HFNC in acute pulmonary edema. You need to go see this trial whether acute pulmonary edema patient performed better. You got the point? So just don't go blindly with this kind of various causes thing. I would call technique working in various conditions when it satisfies individual subgroup analysis. Okay, for example, I have a trial 2. Here they have classified all the subgroups individually. Okay, the first subgroup is pulmonary edema, the second subgroup is ARDS, the third subgroup is viral pneumonia, fourth subgroup is COPD. So they have subclassified them. Okay, and they have checked HFNC versus NIV individually in each and every subgroup, and all the subgroups it has performed better. Then I will name it as HFNC is working in various causes. You got the point? You can't mix up every patient and come out with a conclusion. Rather, do a subgroup analysis, and if it performs well in all or most of the subgroups, then you can claim it to be working in various causes. You got the point? But the issue with these kind of things is, dear friends, if you had done your thesis, you will understand. For example, you would have had a sample size of some 300. When you start doing a subgroup analysis, obviously the sample size of the subgroup will be very, very little, very less, right? So, for example, I am starting to do the same presentation, okay, like a HFNC versus a NIV, okay. I am starting with a sample size of say around 100. If I start doing a subgroup analysis, okay, then each subgroup will contain more or less around 20 or 25 patients only, right? So what type of study I'm going to do with just 25 patients, right? By doing a subgroup analysis, my sample size of that particular subgroup can come down. If I don't have enough sample size, then my outcome is insignificant, right? So that challenge is also there. So think of all these things when you read this kind of trials, okay? So patient may have poor tolerance for NIV due to discomfort. HFNO has advantages of NIV regarding patient comfort and ease of use, which we know already. HFNO offers certain physiological benefits, including improved gas exchange alongside humidification and enhanced secretion clearance. However, HFNO may be less effective than NIV in reducing the work of breathing in acute respiratory failure as such, right? Because if you connect an HFNC in a patient, the mouth has to be closed for the patient, okay? If the mouth is kept open, then the PEEP effect may not be that adequate in HFNC, okay?